Here you can see the very anterior acetabulum. This is the pincer lesion. Femoral head's below us. Capsule of the hip is above us. The labrum is to the left. This is an Arthrocare, what we call an Arthrocare wand. It's a radio frequency wand. And I'm using this to define the area of pincer impingement. This is very anterior. Now I'm using a 4mm burr that we place through an anterior portal and through the hip capsule, upper right. And using this, then I remove a small amount of bone, goes slowly, very anterior here, then extending. Upper left is the more anterior lateral. And you can see the frayed edge of the labrum coming in here. I try not to suction too much to pull much of the labrum in, but there are loose edges that all clear up at the end, but you can see how the labrum is quite damaged to the very left. And I'm removing bone slowly. I use x-ray during this, so I have this patient lying on their back, what we call supine, and I have x-ray in to check in addition to just seeing it visually. Here I remove the inner aspect of the capsule, it's called the synovium, just enough so I can see the extent of the pincer lesion. And you saw there the very leading edge of that pincer lesion. Oftentimes it'll be very hard, or what we call sclerotic. Here I'm just very anterior. I'm going now more anterolateral towards the outer part of the hip joint. And again, checking it with the under direct vision, like what we see here, and also with x-ray, so I don't over resect. You know, I'm trying to remove what needs to be removed, but not more. You can over resect here and destabilize the hip if you're not careful. And so now you can see I'm clearing soft tissue, fibrocartilage, synovium. I'm lifting the capsule off its attachment here. Usually don't completely lift it off its complete attachment, but depends on the degree, the size of the lesion. I make a capsulotomy there in the front, and I try to keep it as small as I can. If I connect the openings in the capsule where I have the scope, what you're seeing through, and then also this working portal very anterior, I'll repair it. This is again making my way up the anterior wall of the acetabulum or socket, up along the very anterolateral acetabulum, and I just remove what needs to be removed. You get a sense when you look at these where you should stop. The bone will build up over time. So these patients have a propensity for this, or predisposition to developing this. And then over time, as this continues and as this continues to impinge and the bone becomes irritated, you'll get overgrowth of bone. So you can see now I'm trying to make the transition from the abnormal area of pincer impingement to the more normal area smooth, and destabilize the labrum as small as I can. In some of these cases, quite frequently, I'll destabilize the labrum when I remove this bone, and I'll repair it. But in this case, you can see here there's very little labrum remaining. Labrum is quite damaged, and quite frequently we'll see this in pincer, where because of the nature of the impingement, the way the femoral neck strikes against the front edge of the socket, the damage to the labrum can be even greater than we see in cam impingement. And so you can see the bruising there of the labrum, very, very anterior. And now we're getting to the more anterolateral side of the hip, front side of the hip. And I'm just removing the loose edges, the parts that will possibly break off as time goes on, and leaving what I can, because this labrum is a very important functional structure. It creates a seal around the femoral neck, and so I want to leave as much as I can. And now you see it left there.